Thank you very much. Any other questions? Thank you very much. Maybe if I write, next picture is Zubek. Anesthesia is a very good friend of surgeons. Maybe that was my answer. So the presentation title is Intensive Therapeutic Aspects of Acute Pancreatitis.
Ladies and gentlemen, dear colleagues, first of all, I would like to thank the organizing committee for inviting me to this congress. I am László Zubek, an intensive care physician from Semmelweis University. We started working with Professor Péter Hegyi and his team half a year ago, but during this short period, we had many common patients. I would like to talk only about severe acute pancreatitis and relations to intensive care therapy. When I started my presentation, first I wondered if there is any Hungarian intensive care recommendation or guidelines that could help us to treat severe acute pancreatitis. What do you think? Is there such a thing? I show you the correct answer is yes. This recommendation made in 2006, and this was valid another 3 years. Because of this, I only found a slightly old-fashioned guideline. But I think this is a good option to make a new, better one. What is the definition of serious acute pancreatitis? It is acute pancreatitis which causes organ failure, and it persists more than 48 hours. CEP can cause every type of shock states like hypovolemic, cardiac, obstructive, dilatative, a majority septic, renal or respiratory failure. SAP describes around 50% of all patients with acute pancreatitis, and they have increased mortality risk. We have a lot of systemic and specialized scoring system. Apache CAT2 is a more worldwide scoring system. If the Apache number more than 7, it means the patient has increased risk, and we have also systemic specialized scores like Rison score and NLA ratio. The number of the frequency of systemic complications between 5 to 50%. There can be transient or persistent. The mortality, the average overall mortality rate is 1 to 5%. These patients has respiratory failure, renal failure, cardiac failure, and also infection. How can we predict the severe outcome of acute pancreatitis in the gastroenterology world? My advice is that you must use any scoring system once or several times a day, which can assess the patient's condition. The most common such point system is BICEP. The patients get 1 point for each following criteria. If his or her blood urea nitrogen level more than 9 millimole per liter, or the patient has impaired mental status, or you see the signs of systemic inflammatory response syndrome, or the patient is more than 60 years and the patient has pleural effusion or radiography. The sequential organ failure assessment SOFA score predicts ICU mortality, but quick SOFA helps to screening organ system insufficiency among internal medicine patients. The three most important vital organ systems are consciousness, circulation, and respiration, and Q-SOFA monitor these organ systems. If the patient's systolic blood pressure below 100 mercury millimeter, or he or she has altered mental status, or the respiratory rate of the patients above 22 per minute, get 1 point, and 2 or more than 2 points suggest the greater risk of pure outcome. If you perceive the clinical symptoms of organ failures, your patients need intensive therapy. It means you feel acute kidney injury, reduced urine output, marked delirium, the signs of circulatory failure like hypotension, bradycardia, tachycardia, or the patient has significant dyspnea or increased work of breathing or hypoxemic respiratory failure. These patients need ICU immediately. I will talk only 3 most important ICU topics in severe acute pancreatitis. First is fluid resuscitation, when and which fluid should be used, what is the optimal fluid infusion rate, and how can we measure the response for early resuscitation. What is the preferred pharmacologic approach to persistent shock? The second is pain control. The next is indications of mechanical ventilations. And the last is non-operative approach to the abdominal compartment syndrome. In 2019, the World Society of Emergency Surgery made a recommendation for the treatment of acute pancreatitis. This recommendation included the following: continuous vital signs monitoring in high dependency on persistent organ dysfunction and organ failure occurrence despite adequate fluid resuscitation is a very remarkable indication for the ICU treatment. Early fluid resuscitation is indicated to optimize tissue perfusion targets without waiting for hemodynamic worsening. And maybe the decrease of overall mortality observed over the last decade might be due to prevention of pancreatic necrosis by maintenance of microcirculation. What does goal-directed fluid therapy means? It means a personalized measurement-based fluid replacement therapy. The American Gastroenterology Association made a similar recommendation. They suggest the goal-directed fluid therapy, balanced crystal diffusion usage, and they suggest against the use of hydroxyethyl starch hash infusions. In 2013, Grunewald and his colleagues published an article in the annual update in intensive care and emergency medicine. They claim that the future of hemodynamic stabilization in the goal-directed therapy. This hemodynamic stabilization consists of 3 steps. The first is examine the fluid responsiveness and optimize the preload. In this case, you have to administer fluid bolus, and the next second step is the measuring contractility and how can we influence the contractility. And only the third step is the use of vasoactive therapy. In this case, we are administering mainly noradrenaline. 1 year later, Professor Zsolt Molnár and his colleagues published another article in the annual update in intensive care and emergency medicine. And they made the idea of a hemodynamic puzzle. What does it mean? It means that every data, every measurement can help us in the decision-making process of the hemodynamic optimization. Intensive care physicians are using cardiac ingress, stroke volume measuring, and carbon dioxide gap, oxygen extraction ratio, and we can measuring the tissue oxygenation with NIRS. Bedside hemodynamic monitoring consists of basal and advanced measurements. Basal steps is clinical examination and invasive arterial monitorization of the patients. You must keep the mean anterior pressure above 65 mercury millimeter. And the last is a prelude monitorization and fluid responsiveness exam. Advanced measures are cardiac output measurements, contractility, and left ventricle function measurements, and tissue perfusion measurements. On the ICU, we can measure in different static and dynamic hemodynamic parameters with invasive and non-invasive techniques. On the left side, you can see a cardiac echo picture. With this non-invasive technique, you can measure the dimensions of the left ventricles. And from this data, you can calculate the ejection fraction and cardiac output of the heart. On the right side, you can see a PICO module. This is an invasive hemodynamic technique. And this adds a lot of information about fluid responsiveness, cardiac output, contractility of the left ventricles. The second topic is pain control. On the ICU, we are using an analgesic ladder against acute pain. The basic treatment is parenteral acetaminophen therapy, for example, 1 gram acetaminophen in every 6 hours. The second step is parenteral opioid doses, pain dose, low dose ketamine infusions, and alpha-2 agonists in Hungary. These are clonidine and dexmedetomidine. The third step is intravenous lidocaine infusion or NSAID administration, or sometimes gabapentin, and only the last step is intravenous opioid infusion. Non-steroid anti-inflammatory drugs should be avoided in acute kidney injury, and we well know that opioids may promote ileus, interfering with nutrition and potentially increasing the risk of abdominal compartment syndrome. We can use patient control anesthesia. Hydromorphone hydrochloride is the preferred drug over than morphine or fentanyl. And some cases we do epidural analgesia. It could be an alternative or an agonist. Epidural anesthesia has a lot of advantages. It makes a sympathetic blockade and better abdominal blood flow, and it can stop harmful vegetative reflexes. It causes better bowel movements, and it can decrease intra-abdominal pressure, but it has a few disadvantages also. it can cause hemodynamic instability, spinal cord injury, septic complications, and this technique prohibited in the case of coagulation disorders. Both non-invasive and invasive techniques can be used, but invasive ventilation is mandatory when bronchial secretion clearance starts to be ineffective or the patient is dying. Increased systemic permeability could precipitate pulmonary edema after wrong and too much fluid resuscitation. The indications are hypoxia if the arterial oxygen level below 60 mercury millimeter, or the patient has hypercapnia over 50 mercury millimeter arterial carbon dioxide level, or if the patient has elevated work of breathing. I mentioned decreased bronchial secretions also. And you can see the non-invasive mask, face mask, full face masks, and helmet that we can use with non-invasive ventilators. The indications are increased dyspnea, tachypnea, and signs of increased work of breathing, accessory muscle using, and abdominal operative movements, or the patient has a diminished gas exchange. It means partial carbon dioxide level more than 45 mercury millimeter, or the pH below 7.35, or naturally if the patient is hypoxemic. We have a few contraindications. Absolute, these are respiratory arrest and unable to fit the mask to the patients or relatives. If the patient's medically unstable, agitated, uncooperative, unable to protect own airways, he's swallowing bad, or the patient has excessive secretions. And the last one, the fourth ICU problem is elevated intra-abdominal pressure. It means the patient's intra-abdominal pressure more than 20 water centimeter. And in this case, deep sedation and paralysis can be necessary to limit this procedure, and increase systemic permeability induced by systemic inflammation and therapeutic attempts such as too much fluid resuscitation and vasodilative drugs are associated with gut failure and worsening of intra-abdominal pressures. And we also give sometimes excessive sedation. And in this case, you have to limit the usual ICU medications like opiates when these side effects overcome benefits. When can I advise to dear colleagues who treat acute pancreatitis? First of all, use disease-specific scoring systems and global illness severity scores in every day, like BICEP, QSOFA, and Apache. To recognize the signs of organ failure in case of severe acute pancreatitis, call an intensive therapist immediately, and always think in a multidisciplinary approach. Thank you very much for your attention.
Thank you very much. It's a very important take-home message for everyone. Any questions?
Thank you very much, László. My question would be about the period before the intensive care unit. because I think this is one of the crucial periods. I am not attending, unfortunately, many intensive care specialist presentations, but we were together on Thursday, Jean-Louis Vincent presentation, which was almost shockingly impressive and fantastic. And he very much highlighted that one way to decrease the number of patients at intensive care is to look even closer the time before the intensive care. And he highlighted the importance that the intensive care specialists visit the floor, the ward before, and maybe 2-3 days before the patients go to the ICU, every day see this kind of patients. How difficult you see it in Hungary. We have very good experiences and other experiences as well concerning the colleagues thinking about the pre-intensive care period, how close this intensive care specialist should look at. My second question would be about your opinion about the high dependency units, which is very much missing in gastroenterology, but not only gastroenterology, other diseases as well, for this period to make a bridge between the ward and the intensive care.
I have to start the second question. My answer is in every international, every ward needs this kind of special beds, and these severe pancreatic patients, you have to lie in this specialized beds. The problem is the intensive care capacity is very low, and sometimes I think the patients may profit if he or she get immediately to the intensive care unit, but we sometimes made a little delay, and this problem is increase the problems of the patients and diminish the status, the physical status of these patients. And how can we diminish this delay? This is the question.
Okay, any other questions?
So thank you very much. Unfortunately, we just got the information from Kata that she's back pain, and it was so serious that she counted, and she is by her heart she is with us, but she apologized the last cancellation, but she said she couldn't do anything else, just